Hello and welcome to this session, an update on the Every Woman Study Low and Middle Income Edition. I am Frances Reid, Director of Programmes for the World Ovarian Cancer Coalition. As you may already know, this study is a joint project between ourselves and the International Gynecological Cancer Society. We've developed it from our 2018 study to be run specifically in low and middle income countries through hospitals. We're currently in the early stages of data collection and in gathering evidence on the state of ovarian cancer care in each of the countries. And our aim is to provide data at a national and global level to drive targeted programs of change. So why the LMIC edition? That's because 70% of women who develop ovarian cancer in the world live in low and middle income countries. Our study in 2018 had a good response rate, but 95% of those respondents came from high income countries. So there was a clear data gap. That's why it's important to collect this information. And it's even more important given that projected increases in the incidence and mortality for ovarian cancer are set to go up significantly by 2040. So we're expecting up to 40% increase in incidence and up to 50% increase in mortality. And this diagram on the right-hand side of the slide shows that in Europe, that increase is just going to be something like 9%, whereas in Africa, it'll be nearer 90%. The greatest burden of increase will be in developing countries. So it's really important they have good data to be able to act now to improve the situation. I don't need to tell you as members of the coalition, partners of the coalition, why patient experience is so important. In LMIC, though, it is often talked about the issues being related to access to diagnostics, surgery, and medicines. But surrounding that, there are financial barriers, geographic barriers, cultural barriers, and health literacy barriers. In fact, they all affect all countries, but particularly in LMIC. So if countries are to develop plans that give women the best chance of accessing care, they have to take into account those issues and deal with them directly as they go forward. If you were part of the session yesterday on the International Cancer Benchmarking Partnership study, that's a study looking at survival rates and the differences between them in high-income countries. You will remember there are no silver bullets, okay? There is not one single thing we should all be doing that will help. There are lots of things and they vary slightly country to country. The route to progress is multifactorial and it must involve political will and funding as well. Women need to know about the symptoms of ovarian cancer, and that's particularly important if they meet barriers along the way to getting help. If they live in a country where if something happens and they don't feel right and they go to a doctor and the doctor does something about it and investigates it quickly, that's not so much of a problem. But if they have to fight to get an appointment, if they have to fight to get somebody's attention that something is really wrong, then awareness is particularly important. But there are issues, of course, as well with access to diagnostic tests, getting into the right centres for treatment, getting the right drugs, getting the right surgery. So no silver bullets. So where are we now with the study? We have 24 countries recruited, and you can see here there's a wide geographic spread and a good spread between upper middle, lower middle, and low income countries. We're expecting a sample size of over 2,000 women. That is based on each of these countries achieving their own minimum sample sizes so that they have some good data that can stand alone. And the survey is being run through hospitals. It's the only way we can access sufficient numbers of women. The survey is now in 31 languages, or almost in 31 languages. We're nearly there with all the translations. And women are able to participate in a number of different ways dependent on their setting. So they might be offered a secure email link, a secure WhatsApp link. They might be offered a paper copy in the clinic to complete, or they might be offered the help of somebody to sit with them and go through the survey. It's really important that all women can participate as much as possible. We're also in the process of doing our country lead interviews. We've done 17 now, and these are semi-structured video interviews which are then analysed thematically. They'll be followed up with in-depth survey questions, and the information from this will give us added context for the incoming data, and it will help us to highlight and articulate the key challenges and opportunities. Themes that come first to mind: lack of data. Lack of data to help plan, to help decide what's best, to help decide what needs changing. Issues around accessibility and affordability of diagnostics and treatments. So it's not just treatments, it's about getting the diagnosis. A lack of genetic testing. In fact, responses so far reflect the wide variety of circumstances. We have countries such as Malaysia, which are upper middle income countries, which have a number of specialist centres treating the disease, to other countries where there's only one centre that treats cancer patients in the country. So very wide range of experiences. And the clinicians reflect beyond the medical issues, delving into cultural, financial and gender barriers. And we're going to give you a little flavour of what they said now. First up is Professor Wu Yinling, who leads our Malaysian site, and she talks here about the benefit that she sees of being part of the study.
So one of the real benefits of participating in the Every Woman study was the fact that we could get opinions and how patients and women felt themselves. As clinicians and healthcare professionals, we got a rough idea, but we've never really documented them properly and systematically. And this study has really allowed us to do that and to really meet women everywhere throughout the countries in the different states where women are participating. And it's allowed us to speak with them in their different languages and meet them at their point of need. We've met lots of patients now where we explored areas that we've never done so before, particularly during the time of the COVID pandemic. The other thing that's really good that has allowed us to engage with patients more is in terms of the family and the social demographics, their financial situation, and how their family members play a role in their decision making. A few patients were quite excited to find out that their opinions will eventually form policy and for us to advocate for them. And I think that's a very powerful thing which we hope will come to fruition in the near future.
Professor Wu Yinling from Malaysia. Our country lead in Kenya, she said this in her interview, Dr. Afrin Shafi. She was talking about the barriers that she sees sometimes because of women's role in society. And in Kenya, it's often the case that the women are dependent on their husbands for national health insurance plans, and in other countries also on even permission to go to the hospital to seek help. Here she describes the case of a woman who was diagnosed with ovarian cancer, was counselled, and she accepted that chemotherapy would be a good way forward. But after the husband learnt of her diagnosis, he abandoned her. Not only did he abandon her, he removed her as a beneficiary from his national health insurance plan. So she had one cycle of chemotherapy, and after that, she just disappeared. There is a big issue with not being able to complete courses of treatment, and these are real problems that lead clinicians and the clinicians in these countries face every day. Dr. Tom Connie is our country lead in Ghana, and here he talks about the challenges that he sees because many women often seek help from alternative healers before they come for medical help. This is due to a lack of health literacy. And as you'll hear, it's quite shocking what happens before women actually come to see him.
Sometimes, even if they are told that it's more likely to be an ovarian cancer, the cultural belief is saying that you can't have a cancer. There's something, or somebody has bewitched you, somebody has planted something in your abdomen and it's growing that fast, for which reason you don't need medical or surgical care. What you need is a spiritual or any other form of treatment. That is going to be by herbal treatment. And most of these patients are given concoctions to drink, concoctions to even use as enema. The enema, you'll be told that, yes, this is going to let whatever is in your abdomen come out after the enema. So they'll do all these things, these things don't work. Then the other social one is not coming to the hospital, but going to see spiritualists and some, I'll put them in quotes, local, they'll call them surgeons, because what they do is they use knives. They don't do surgeries, but about 75% of our women who come in with the enlarged abdomen always have some scarifications made on their abdomen. Scarification marks made by either broken bottles or by sharp knives.
Dr. Tom Connie from Ghana. So our data collection is underway. We have 6 countries collecting data: Malaysia, Kazakhstan, Brazil, Kenya, Argentina, and Peru is the latest one. 203 women so far, predominantly from Malaysia, Kazakhstan, and Brazil. 10 sites are collecting at the moment. So lots of sites still to open, but we're already seeing some really interesting data. So the average age, median, is 54. Just a third of women being diagnosed at stage 1 or 2. And interestingly, even with this group, for just over half, the highest level of education achieved was secondary school. And for 1 in 5 women who've participated so far, they never made it beyond primary education. Over 10% have travelled 5 or more hours to reach the hospital, and 4% have travelled more than 24 hours. Over half have caring responsibilities, most commonly children, and over half are in employment. These are economically and socially active women playing important roles in our society. Just 7% did not experience any symptoms, and by far the vast majority of women experience symptoms that we know are commonly associated with ovarian cancer, common also in less serious conditions, but classic symptoms of ovarian cancer. Just under 3 in 10 are reporting that diagnostic tests are free, meaning 7 in 10 say they have to pay to get diagnosed, and just 45% reporting that treatments are free. Family finances have been affected to a great extent. 1 in 5 who've needed emotional support, and that's most women, have found it very challenging to deal with the stigma of a cancer diagnosis. And 9% said they needed emotional support when their partner left them. I find that quite shocking, really, to find such a rate of abandonment. So just gives you a bit of a flavour of what's coming in. We can already see there are differences between countries that will emerge, and these figures will change as we go through the study, but some really, really interesting data. We'll continue to collect information until the end of June 2023. Then we'll do the global analysis and the national reports. We'll be working with teams to disseminate their results, prepare publications, and explore opportunities for action. And this is just the start for many of the teams. Our Nigerian lead, Dr. Aisha Mustafa, she's just one of many of our country leads who are so enthused by being able to participate in the study and say that this really is the starting point for a lot more activity in future.
My name is Aisha Mustafa. I'm a medical doctor, a consultant obstetrician and gynecologist, specifically working in the gynecology oncology unit at Ahmadu Bello University Teaching Hospital in Zaria, Kaduna State, northwestern Nigeria. I basically work in gyne oncology and I see only gyne oncology patients. And I'm actually the country lead for the Every Woman study in Nigeria, and I'm super excited participating in the Every Woman study for low and middle income countries. The Every Woman study for me, being on the team, is actually shall I say, I feel honored to be part of the study. And why I'm actually excited is because this is the first time we in Nigeria are conducting a multi-center, specifically a 12-site study, prospectively recruiting women with ovarian cancers in the 6 geopolitical zones of the country. And with this will help us actually identify the key challenges these women are facing and actually document them, because some of us know the challenges, but these have not been documented in such large scale. And apart from identifying these challenges, it will also help us to provide the opportunities on how we can improve the overall survival of these women by actually getting policy statements from such research. That's for us generally. Then to me personally, I'm actually excited participating in this study because it is actually improving my own capabilities in research. I have not participated in such study before, and I am seeing how this is going on from the beginning through when we started almost a year ago. And it has actually opened my mind to future possibilities, future collaborative researches among the members of the 12 sites participating sites and also the international community and even beyond. So this is actually helping my own research capability. And I also see us collaborating for the future after providing a database for ovarian cancer patients. And of course, with their permission, we'll be able to call them up and probably do even more research based on the number on the women that we have recruited for this study. I actually believe that this study will change the future for ovarian cancer care in Nigerian women, and also for us, the researchers that are participating in it. Thank you.
That was Dr. Aisha Mustafa, our Nigerian lead. And huge thanks go out to our country leads who are listed here. Some of them are also members of our oversight committee, and without these groups, we would be nowhere with this study. They are working really, really hard to get the study off the ground in their country and to get that data that will really begin to help them prioritise what needs to be done. And our thanks also go to IGCS, who have been an incredible partner on this study and helped and supported us in terms of reaching out to the clinical teams in the different countries. So that's the end of my session now. You'll be able to join my colleague Phaedra Charlton straight after this session by clicking on the Sessions tab on the left-hand side. And she's going to talk to you about World Ovarian Cancer Day in 2023 and partner resources that will be available. Thank you very much.